This year we try to really focus on different topics in oncology because this year has been a year with many breakthroughs that have changed the care of patients and how we deliver the care on an individual, personalized way. The participants that are here, these are people that are the people of the next generation that can make an impact. So their interaction with these thought leaders is creating a tremendous mix. And this mix is going to be special to moving our field forward, to making that game-changing innovation that can change the field of urology and medicine beyond what we think today.
We talked about BCG shortage and new agents considering bladder tumor, especially non-muscle invasive bladder cancer. This was a very interesting topic because we brought new literature to the discussion and also to discuss with friends, with renowned leaders in the area. Was very, very thoughtful to be here. This meeting is unique because it has so much contact with the public, with each other, with other speakers, and we can really discuss thoughtfully about each topic.
The topic that I gave is on the novel agents for BCG unresponsive non-muscle invasive bladder cancer. As you all know, the recurrence rate is very high after the traditional intravesical BCG treatment. And then for patients with BCG unresponsive disease, we tend to do radical cystectomy, which is a very major surgery for our patients. So always a search for novel agents. So I briefly talk about the currently approved agents for these kind of patients, including pembrolizumab, atezolizumab, as well as intravesical aceclidine. I also updated some really important updates from the ESMO trial, namely the use of oral erdafitinib and also the novel delivery device, the TAR 200 and 210. So essentially, all drugs have been showing really promising treatment efficacy. Some drugs are really showing promising safety profile as well. So hopefully in the long run, these patients will benefit more from this kind of systemic as well as intravesical treatment. I've always wanted to visit this institution, namely is because it's very well renowned, and also I feel Prof. Sherritt as a role model since I was very young.
My topic today is about localized prostate cancer, the management and the staging of this disease. Also, I introduce a new tool for the stratification of the risk of progression of early prostate cancer, mainly imaging with MRI as example, but also a molecular marker which could be used to stratify the patient and identify aggressive or non-aggressive disease in order to show the best management. As example, active surveillance or multimodal therapies. It's a relatively small meeting and we can have many interactions with other urologists, oncologists. It's a transdisciplinary meeting.
This meeting is extraordinarily special. It's really a highlight of my academic year, typically. It's an opportunity to get together with friends and colleagues from around the world to discuss the most exciting topics in our field and really hear from international experts like Dr. Heidenreich. Today I'll be talking about the value of collaboration, specifically talking about the Michigan Urological Surgical Improvement Collaborative, which is a group of physicians in the state of Michigan in the United States working together to improve the value of care to our patients.
My topic was the surgical management of patients who have residual disease after systemic chemotherapy, which is usually a kind of a challenging surgical procedure, which needs to be done in expert centers, and just I demonstrated the anatomy and the different approaches to this type of residual masses. You really gather expert in these different fields of uro-oncology, and then you get the latest information about new developments, which usually not have been published so far, or at least you have these expert opinions, and you have this nice exchange between international people.
Today I was asked to talk about a salvage therapy for patients who failed the first-line BEP cycles 3 or 4 and also failed surgery. And there are actually not a lot of new data, but I think it's important to keep in mind that high-dose chemotherapy is the first choice in most of the patients, nearly all of the patients, and further chemotherapy is only palliative. So what we want to do with the high-dose chemotherapy is to cure the young patients in our hands, the testis cancer patients. This year it is so special because the focus is on testicular cancer, on germ cell tumors that do not have a big lobby. It is a rare cancer, but it is the cancer with the highest incidence in young men.
The management of low-stage seminoma has evolved over the past decade or so, given the toxicities of prior standard approaches to low-stage seminoma, including second malignancies and cardiovascular events at younger age. That has led to exploring surgery as an option in the management of these low-stage patients, relapsing stage 1 or stage 2. And there are 5 separate investigative groups that have reported their results, very promising, and it appears to be emerging as a very viable alternative for the management of these patients. It's a tribute to one of the giants of urologic oncology. It has attracted really experts in multiple disciplines from various countries. So it's a very high quality scientific meeting, and the hospitality is unmatched. And this is a beautiful city.